Good afternoon, everyone, and welcome back to Systems and Sustainability Echo. My name is Shreya Prasad, and I will be your facilitator for today's session. Some housekeeping before we get started. These sessions are enabled for live closed captioning. If you would like to view closed captioning for this session, please navigate to the bottom of your window and select the Show Captions option. We are recording these sessions for later distribution through the BWell YouTube channel. Please know that anything listed in the chat will not be shared in the recording. As always, please stay muted unless you're speaking, and we do encourage you to speak. If you've joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6. We encourage everyone to join by video, especially for the discussion portion of the session. That said, regardless of how you've shown up here, we are just happy you're here to learn alongside us and share your perspectives in today's discussion. Because there's a lot of us here, we ask you to keep your comments brief to allow space for others to speak up. You can also use the chat feature to raise comments and questions. Please note that no protected health information is allowed in either the chat or the discussion, and that includes names, emails, addresses, or anything that can easily identify an individual. To help us with attendance, please enter your name, email, and affiliation in the chat. To all the BWell Texas providers, please make sure that you identify yourselves during the session. If you are joining via phone, please email your name and phone number to bwelltx@ithaca.edu. Towards the end of the session, we will send out a link to an evaluation survey. Please fill it to be entered into a drawing for a $30 Walmart gift card. Our didactic today is on Don't Overthink It, Aligning Addiction Care with Community Needs. And this will be presented by Alanna Boulton. Following that, we will have some announcements from the BWell program, and we will hear a systems case from our learning community. As always, I encourage you all to share your questions, feedback, and insight in today's conversation. And with that, we will do some introductions. Matt.
Hi, everyone. Welcome. Good to have you with us. My name is Matt Rosa. I work as a consultant. My background is in clinical social work, agency administration, governmental planning. Now I mostly focus in the areas of quality improvement and best practice implementation. Thanks.
Thank you so much for joining us. Leslie.
Thank you. I'm really glad to be here as well. I'm Leslie Manson. I'm a licensed clinical psychologist. I'm also a consultant for integrated substance use, mental and behavioral health, and medical care treatments through integrated healthcare. And I'm also a clinical associate professor and chair of integrated initiatives at Arizona State University.
Thank you so much for joining us. Kathy.
Good afternoon, everyone. I am Kathy Hudgens. I also am an integrated care consultant and expert. My focus is on program building and training, implementation, and state health policy. My background is I'm an LPC, LMFT with a PhD in marriage and family therapy with a focus on medical family therapy.
Thank you so much for joining us. Alanna.
Hi, good afternoon, everyone. My name is Alanna Boulton. I am a program director at Dell Medical School at the University of Texas at Austin, and I'm really excited to be here today. Thank you so much for having me.
Thank you so much for joining us. Jason.
Hello, everyone. I'm Jay Nunez. I am a recovery support peer specialist here with Lifetime Recovery here in San Antonio, and I'm really excited to be here. Thank you.
Thank you so much. Andrea Hebler.
Hello, everyone. My name is Andrea Hebler, and I am one of the program coordinators here at the Center for Substance Use Training and Telementoring. We're a division of BWell Texas at UT Health San Antonio. Thank you, everybody.
Thank you so much. And with that, we will move on to our didactics. Alanna, you can take it away whenever you're ready.
Perfect. Thank you, Shreya. I'm going to share my slides. Someone could give me a thumbs up if they're able to see. Perfect. All right. Well, thank you so much for having me today. Again, so I work at Dell Medical School, and I direct a handful of programs, but the two that are most relevant to our conversation today are the Substance Use Treatment and Resources for Texas program, or the START program, and the Support Hospital Opioid Use Disorder Treatment program, or SHOUT Texas. And both of those programs are dedicated to expanding access for hospitalized patients to receive evidence-based substance use treatment or addiction care while they're hospitalized in acute care hospitals. And I'm going to be talking today about how to develop programming or services within your institutions or your agencies that can best serve people who use drugs or people struggling with addiction or navigating recovery or people with substance use disorders in your clinical settings. There we go. First of all, no disclosures, no financial disclosures to share. And then as always, everything I'm saying today is my opinions as a private citizen and don't reflect the opinions or views of BUL Texas, UT San Antonio, or where I work, Dell Medical School at the University of Texas at Austin. These are my personal opinions. And I do want to do a land use acknowledgement. I'm speaking today from Austin, Texas, which is on unceded lands of Indigenous populations. And it is important, as we'll talk about kind of throughout the rest of this conversation, to recognize and make kind of meaningful, informed decisions around everything that we do with consideration to the land that we are operating on. And then my last acknowledgement is about my lack of lived experience. So I personally am not somebody who has had to navigate addiction or substance use or recovery or healthcare services in the context of using drugs, but I am the daughter, the granddaughter, the niece, the sister, and the former spouse of people who have struggled with and lost their lives to addiction. So I try really hard, and it's one of the things that we're going to talk about today, which is centering the voices of people with lived and living experience. So it's important for me to acknowledge and disclose, I guess, to you guys that I don't have personal lived experience, but I have dedicated my career to making sure that we can do our best for these people who use drugs or who are struggling with addiction. So with that, what we're going to talk about today is how to develop services in your institution or your organization that can best serve people who use drugs or people struggling with addiction. So we're going to do that by describing the holistic picture of the addiction care ecosystem. And I'm using those words very intentionally. You'll see nowhere on here does it say substance use treatment or addiction treatment. It's addiction care. So it's the care of people who have addiction or struggle with addiction. Then we're going to identify evidence-based best practices that we know work for people who are struggling with substance use or who are interested in finding a patient-directed definition of recovery. And then, of course, we're going to talk about a little bit more practically how you can actually implement those ideas, those strategies in your organizations. And it's the title of the talk, Don't Overthink It, right? So how do you align your services with community needs? Two things, right? You ask your community what services they need and you do what the evidence says works. And that's it. That's the talk. It's been, where's the timer? It's been 1 minute and 28 seconds. That's all I have for you guys. I'm joking. That's not right. Don't fire me, Andrea. So I've oversimplified it on this slide, but I think it's because we as healthcare providers, or specifically in my context in academic healthcare, we tend to overcomplicate things and we tend to put ourselves up on pedestals or our institutions up on pedestals and don't always take the input of the community into account. So that's what we're going to talk about today. So how do we actually do that, right? I'm not going to leave you guys hanging. I'll actually give you some ideas. So the first piece of how to align your services with community needs is to redefine or reframe the way we think about the idea of services. So services traditionally in the context of addiction care are often considered treatment, rehab, or inpatient hospitalization or intensive outpatient care, medications. I'm a big proponent of medications for opioid use disorder and medications for other addictions, but that's not necessarily where the service line ends. Counseling, sobriety or abstinence support, and then mutual or 12-step AA, NA, MARA type resources, right? This is where traditionally our minds go when we think about addiction care or substance use treatment. But I'm going to challenge you today to expand the way that you think about services. So in addition to all of those things that we just talked about, additionally, so this is an and, it's not a but or an or, it's and, there's other things that should be included in your idea of services for people who use drugs. So that could be harm reduction, which includes infection prevention, overdose prevention, peer recovery support, housing support, food support, money and job training, childcare and custody assistance, transportation, healthcare coverage. I live in Texas, where 20% or more of the population don't have healthcare coverage. That makes finding treatment or resources really, really difficult. And then the idea that recovery is a continuum. What else did I miss? I'll open it up to the group. You can either unmute yourself and talk or put it in the chat. I'll do my best to try to monitor the chat. What other ideas or concepts did I miss on this list that we can consider as services when we're talking about helping people who use drugs find sobriety, however they want to define that? ID recovery, is this, Mary, can you clarify, is that infectious disease? I work in medicine, or is there another term that I'm not familiar with?
I want to say she means identification, like driver's license and social security card.
Identification recovery. Absolutely, absolutely. That's a great thing to put into the chat. That's something that we don't think about all the time, especially in the context of people who are unhoused or are transient or in transitional housing. They've lost access to their identification, which is pretty much required for everything that you need in order to receive services. So that's a great addition. Thank you so much, Mary. Anything else to add to this list before we move on? I'm sure that I didn't capture everything. Recovery from trauma. So yeah, so trauma-informed care, right? The idea that addiction doesn't happen in a vacuum, right? That people who use substances don't just wake up one day and decide like, oh, I'm just going to do this. And then like magically they have ongoing long-term substance use or addiction issues, that there are traumas that lead to and are a result of addiction that perpetuate that cycle. Absolutely. Thanks so much for that, Carla. All right, we'll move on to our next slide. Maybe. There we go. So we've already kind of talked about redefining or reframing the way we think about services, but we also need to reframe the way we think about and define community. When we're talking about aligning services with what the community needs and asking the community what they need, who are we talking about in this instance, right? So again, traditionally in the context of addiction treatment or substance use treatment, we think about subject matter experts, right? So people in your area, your community who are maybe already doing this work, they're already providing services, they already have treatments, clinics set up, service providers, researchers, hospitals or clinic systems that maybe are responsible for the indigent population or vulnerable populations. Public health, we think about that a lot, especially in the context of prevention. And then this is a great thing, but it needs to not be the end, is patients who are in treatment or patients who are already in recovery. It is super important, again, to center the voices of people with lived experience. So that does include patients who are in treatment or who have found recovery or sobriety that works for them. But that's not where that conversation should end. That's not the end of the spectrum of people that we should include in the conversation. So in addition to all of those categories of people, we should also think about all of these other types of people when we think about community. And the first one on this list is on the top of the list for a reason, and it is people who use drugs. So people who currently use drugs. So when we're talking about previously considering patients who have already navigated the system well enough to find some kind of treatment or to find some sort of recovery that works for them, that's great, but we shouldn't only consider those people when we're thinking about how to develop our services, right? We need to talk to people who are currently using drugs, whether they are looking for sobriety, whether they are trying to find some sort of treatment or not. These are the people that we are trying to help or that we're trying to develop services for. We absolutely have to include them in what we think about when we're developing these ideas or these services. So people who use drugs, people with lived or living experience, drug user unions. It's a relatively new concept, at least in the state of Texas. It's not so much in the Northeast or the Northwest, but in the state of Texas, it's a relatively new concept. Harm reduction organizations, recovery-centered organizations, peer support, navigation organizations, housing supportive organizations, first responders. So in this context, I'm talking mostly about paramedics, community health workers, but also fire department, police, the people that are going to interact with people who are in acute intoxication or who have overdosed or who have some other acute medical issue that's associated with, or maybe not, their drug use or their addiction. And then this one's really important: case managers, social workers, community health workers, counselors, those people who interact with the people who use drugs, the people that we're trying to serve, the people that have that like really nitty-gritty, granular critical understanding of how hard it is to navigate the system, right? That how hard it is to find a treatment provider, to get insurance coverage, to find transportation to your treatment provider, to get to an AA meeting even. These are the people that know way better than I do and way better than most of like prescriber clinicians do. And then also the families of these people, families of people who have found recovery, who are in treatment, who are still using drugs, who have loved ones who are no longer with us, who've lost their lives to addiction. It's important to include those categories as well. And again, I'm going to open this up to the group, and I'm comfortable with awkward silences. So what other categories of people or community members have I left off of this list? Who else should we go talk to about how to develop services or what services are needed? Again, feel free to put it in the chat. Feel free to take yourself off mute. I think we're allowed to do that. Shout it out. I've got neighbors. That's a great one. Yeah. So especially when we're talking about housing support for folks who are either in transitional housing or who are struggling with homelessness, the neighbors, the people that live around them, the people that see them on the streets, or the people that live close to the transitional housing centers, those are really important people to include in the conversation. Let's see, we've got lots here. Kristen. Oh, I missed one. Go ahead.
Families.
Families. Yep, absolutely. Kristen says students. We've got Matt saying schools. Yes, absolutely. Especially when we're talking about the idea of prevention and early intervention for adolescents. Absolutely. Students, schools, sober living houses. Absolutely. Thanks, Chris. Youth groups, Mary, that's a great idea as well. I don't work a lot with adolescent populations, so you can see my implicit bias in these slides, that a lot of the things that I listed on here don't necessarily apply to adults, you know, schools, students, youth groups. So that's a really great, actually, like, application of what I'm trying to say is we really need to expand the way that we think about the community. And I even left off like an entire category of things up here because it's just not what I think about on a day-to-day basis. Educators, again, same thing. Schools, people with living experience with homelessness. Yes, absolutely. Criminal justice departments, Kimberly, that's a great addition. We work closely with our county jail and the medical providers at that county jail, but that's a hugely underserved population. Absolutely. Jason, how our reporters speak. Yes, absolutely. Kathy, this is a great one. Grantors, so people who have money, people who are funding the work that we're doing, what do they want us to do? Churches, also a really good addition. Government agencies, you guys are like nailing it. So great. So we're already thinking about the ways that we're going to expand our definition of the community that we're trying to serve. So excellent. Thanks so much for all of your engagement. So now that we know, we've kind of expanded our definition of who we're going to ask and what we're going to ask them about. How do we actually do that? So asking our community about the services they need, how do we like actually do that in real life? And I've simplified this down, but of course it's more complicated than I make it look on a slide. But the answer is relationship building. That's something that we as a medical system, especially in academic medicine, don't do a great job of. We think of ourselves as kind of the end all be all. We are the ones that get all of the funding. We are the ones that know the best. We do the research, we read the research, and we don't always do a great job of making friends with our community, right? So I don't know if you remember way back on the very first slide, I have a lot of letters after my name, but none of them are clinical. One of them is a PMP, which is a project management professional. And one of the like key tenets of project management training is communication and stakeholder engagement or relationship building, which is really, really important to success of any kind of project in this case, which is like building services to provide to the community. So how do we actually do that? The first thing you do is you have to figure out who these people are. We just listed a bunch of categories, but you need to figure out who in your community is actually falling into these categories, right? And you can do that by Googling, by asking around. Likely, if you're attending the session, you're already working in this space, you probably already have a decent idea of who these people are in your community. But do some research, ask your colleagues, ask the people that you already know, who's doing this work, who could use our help, who has great ideas and no funding, right? Or who has, who really wants to make a difference, or who wants to like really try something new and exciting. And then go make friends. I very specifically put make friends on this, not like build relationship or say hello. Like you really need to go establish yourself as a as a member of a community or a member of a coalition, right? The reason that we've been successful in the work that we've done in Austin here at Dell Med is because we really, really built relationships with the whole ecosystem of addiction services in Austin. We're all in this together. We all have strengths and weaknesses and areas that we really excel in and areas that we need to do better at, or areas that we're not experts in. And it's really important for us to work together as a team, as friends, to do this work together. We cannot operate in silos. There's no way that that's successful. And then you have to be prepared to invest time and effort in that, right? This is not like send one email, make one phone call, and then there you go, you're done, right? This is like ongoing relationship management, just like you would do with your friends, your boss, the person that's paying you, like your funders. Invest that time and effort. Especially in the context of this work, consistency and reliability is really important, right? If you say you're going to follow up, follow up. If you say you're going to go somewhere and be somewhere, or see somebody, go somewhere, be there. You know, don't give anyone an opportunity to think that you are unreliable or that you are not interested in working in that really collaborative environment, right? And then this last one, be open, right? Approach this with a mindset of curiosity. Again, if anyone on this call is probably already working in this space, probably is more informed than the general population or the general healthcare population in this context. But again, for me specifically, like I work in academic healthcare and I don't have personal lived experience. So when I go and I talk to our RCOs or the peer support folks that we work with in the hospital, I go to them as the experts. I do not approach them as an expert. So I'm going to be open. I'm going to listen to what they have to tell me with the ideas that they have and the things that they know work and the things that they know don't work. Addiction is sort of evolving, or at least we're becoming more comfortable with the evolution of addiction on a spectrum and recovery on a spectrum. And so you may be exposed to ideas that make you uncomfortable or that you don't understand. So just be open and be curious when you see those or you're encountering those sort of ideas or thoughts. And then how do you find these people? There's lots of ways. I mentioned this a little bit before. Ask around. You're probably already working in this space. You can Google. Also, this link, which I think will get sent out on the slides, is for a drug users union directory. Not every drug users union is in here, but some of them are. I think there's like 4 or 5 in the state of Texas. And there's also RCO directories that are out there as well. And then how do we actually do that, right? How do you do that make friends part? How do you actively work together with someone? And so what you want to do is what's on the left side of the screen, right? So that Venn diagram of everything they do and everything you do, and where is that overlap? And you really want to leverage that overlap, right? And hopefully eventually you can expand that. You can make that Venn diagram closer to a circle, but you really want to exploit, which in this context is not a bad thing. You want to exploit that overlap, right? The things that they are doing and the things that you are doing that complement and help each other. It's also important to stay away from some of the things on the right-hand side, which is going to somebody and trying to like bring them into your expertise, right? So again, coming at it is like, I'm the expert, we are the experts in this space. You want to come work with us, right? That's not what you want. You don't want to try to absorb these RCOs or these people or these stakeholders into your current operations. Because again, they have their own knowledge and their own expertise, and you want to work with them, not pull them inside of you. And then that last one, the other thing you really don't want to do, which is the great way to not make friends, is to reach out, learn from somebody, get some ideas, and then ghost, right? And then just never talk to these people again and try to implement the thing that they told you to do. This is a lot of like reinventing the wheel, right? These people, these agencies, these organizations, these are the experts in implementing harm reduction or implementing, recovery first or recovery support or whatever types of interventions. Let them be the experts. Don't try to take their ideas and implement them yourself, especially if you don't have that lived experience and that actual practical understanding of what you're trying to do. It won't be successful, and you're going to alienate that part of the community, right? And you're going to put patients at risk, right? Patients that are people at risk who will have potentially negative experiences and then be less inclined to try to reach out for help later when they need it. And I think I'm getting close on time, so I'm going to sort of buzz through the rest of these. But so the first answer was ask your community what they need and do that, which is what we've talked about. The second thing that I put on that very first slide was do what the evidence shows works. And fortunately, there are people out there who are much more intelligent and much more established at research than I am. And they have very graciously put together all of these resources for us to know what the evidence says does and does not work. So go to the experts, right? Again, we talked about experts in the context of the community, and now go to the experts in the context of the science, right? So these are from Johns Hopkins, CDC, and the National Academy of Medicine, have put out all kinds of guides. These 3 specifically are about opioids, but there are guides out there about alcohol, tobacco, stimulants is kind of on the rise, and then psychedelics is sort of out there as well. And they've already done the research. They've already done the hard work about figuring out like clinically what works and what doesn't work. All of these are free and freely available, and I think they're all listed on my reference slide as well. The other thing that you may have access to, depending on where you live or where you work, is community needs assessment. So again, I live in Austin, which is in Travis County, and Travis County pretty consistently every couple of years does some sort of a needs assessment around substance use or behavioral health things. So there's ones here from 2015, 2019, and I think that last one is like 2021 or so. And so that's the county itself took that task on about finding the community, bringing the community together and assessing the needs of the community. So again, they've already done the hardest part of work, which is figuring out what the community has to say and putting it together like a very nice document that you can just read. So do some research, do some Googling, see if your county or your area has done something similar, or you can come read the ones from Travis County. They may be somewhat applicable to your setting depending on where you are. But there's lots of people that have already done the harder work first. And then I'm going to put this up there because it gets into the little bit more of the nitty gritty. I don't expect you to read this entire thing today, but it's actually probably maybe a good thing to do. So Johns Hopkins recently put out this guide, which is their suggestions of what they, according to their research, think that counties and states should do with the dollars that are coming down from the opioid litigation settlements, which Texas is included in. So they've got these 5 guiding principles and then their 9 core strategies. I'm not going to read all of them to you just in the interest of time. But I want to point out the first 2 in the guiding principles, which is spend money to save lives. We need to do what works to keep people alive. And then use evidence to guide spending. So again, the evidence is what the researchers have showed works and what our community tells us is working. And then somewhere in here, it also says harm reduction. It's the second to last one on the 9 core strategies, which I wanted to call out specifically, expand harm reduction strategies, which is something that has been happening nationally for a while, but we are still kind of warming up to in the state of Texas. And in the interest of time, I think I'm going to wrap up a little bit, but I'm not going to play this video, but again, it will be on the slides and it is linked below. But once you figure out what it is that you want to do to influence that change in your organization, you really need to challenge stigmatizing mindsets, especially in healthcare. It's really important to understand the way that the stigma of addiction and people who use drugs influences the way that those people experience the healthcare system, whether that healthcare is specific to their addiction treatment or not. That's really important to tease out. And then I'm sure Andrea or somebody could find the link. We've given a couple talks on stigma for this echo and some other echoes as well that are out there. We're happy to provide additional training or guidance or talks if anyone is interested in that. We're not going to play the video. And then I stole these last 2 slides or 3 slides from one of my mentors, Chris Moriades, who has done a lot of work around the idea of leading from where you stand. So how to influence change when you're not necessarily like a leader in your organization, you're not in the C-suite, you're not a VP, you're not an executive, what you can do. So again, in the interest of time, I'm not going to go through everything on here, but these slides will be sent out afterwards. And I will put in the chat a link to Chris delivering these slides and more. So this talk actually like a larger version of this talk for our Shout Texas Echo about a year ago. That will be super helpful if anyone is interested in trying to figure out how they can actually influence change in their organization. Pitfalls of how to influence change. We won't go through all of these. And these are our take-home points. I saw Shreya turned her video on because I'm taking too long. Sorry, this is the end, Shreya. So this is our take-home points, is expanding your definition of community and services to include the entire continuum of addiction recovery and care. Meaningfully and authentically engage with thought leaders in your community and defer to their expertise. implement strategies that we know work, and identify and reduce stigma in yourself and your organization to influence the changes that you want to see. And then these are my references, and there's the end. I went long, but I think we might have time for a couple more questions.
Thank you so much, Alanna, for this wonderful presentation. And yeah, I will open up the floor for some questions. We may have like a couple of minutes, I suppose.
Could you go back to the reference slide?
Yes. There you go. And I think these slides get sent out afterwards, so the references will be there as well once these are sent out.
Mhm. All right, thank you, Alanna. Please keep the questions coming. Thank you again for the wonderful presentation. Please, you can put any more questions you have in the chat, and I'm sure Alanna will continue to answer those. In the meanwhile, we will move on to the next part of our session. Karen, if you could please share the announcements from BVL. Thank you so much. To claim CME credits, you must text by midnight tonight. Please text attend 1009-5778 to 844-502-1338 to record your attendance. Next slide, please. Please join CSTAT for our next session titled Mitigating Grief and Loss Post-Pandemic. We will be sharing the link in the chat for this webinar. Next slide. Our next Systems and Sustainability Echo is on Thursday, May 23rd at 12 noon. Please join us. Next slide, please. Do you have a case, a difficult case that you or your team have encountered? CSTAT gives you the opportunity to present any challenge your organization is encountering and receive feedback from our help experts and the broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to help with the presentation. Please email us at cstat@utasca.edu. Next slide. The Center for Substance Use Training and Telementoring, CSTAT, offers technical assistance for various substance use disorder needs and topics via a team of experts. To request technical assistance, please complete an online request form and we'll be happy to help you. You can use the link in the chat for the same. And with that, we will move on to our case for today. Jason works with an organization that provides peer support, advocacy, resources, engagement, education for people with SUDs. Jason, could you please tell us a bit about your role in the organization and what are some of the challenges that you're facing currently?
Good afternoon. Thank you so much. Again, my name is Jay Nunez. I am a peer recovery coach, peer support specialist, as we call it now, here with Lifetime Recovery here in San Antonio, which is in Bexar County. Real quick, a little bit about myself. I am a person with lived experience with substance use disorder, and I'm really grateful that I have had that journey. A little bit about Lifetime. So yeah, as you said, we primarily work with people with substance use disorder. We have two facilities. We have a treatment facility, a residential campus, as well as where I work at outpatient. And we work with, I would say about 400 plus participants that come through our outpatient. Our residential will hold up to 80. And we are a nonprofit, right? And so that really does segue into my barrier, which is funding. No, not funding. You know, as a peer support, our role here really is to meet our participants where they're at, right? One of the things I've gotten to learn is that my path is not going to be everybody's path, right? And that's been a really enlightening experience being a person in long-term recovery. And so, yeah, like one of the things that I put down here is we're supportive in a non-judgmental way. We meet people where they're at. We ask them what their goals are, and we help them meet those goals. And, really our objective is to, help guide them back into being productive members of society and into a space that they feel is most comfortable for their life and their growth. So yeah, talking about funding, one of the things that we struggle with is providing services. Sometimes the juggle between quantity and quality, right? And so one of the things that we struggle with is access to services, staff turnover, program cuts, reductions, lack of department growth versus demand. And I know it sounds very technical, but what I do know outside of the funding realm is that there is no price for kindness, compassion, and empathy, right? We are amazing humans and we always find a way to connect and help others. So I really do look forward to like the conversation about where we are able to look into greater funding for our nonprofit programs. And I'm really glad to be here. Thank you so much, Andrea, for asking me, and everyone at Be Well. And Alanna, thank you for sharing your living experience and bringing some new terminology to my realm. And don't overthink it was the perfect beginning for me, right? That is a challenge for someone like me. But yeah, I'll definitely pass it back to you guys. Thank you.
Thank you so much, Jay, for introducing your case. I'll open up the floor for any questions or any comments.
Instrumental has a 2-week trial period, and you can get the full benefit of finding funding, a different variety of funding within that time period, and you don't actually have to pay for it. That would be my start.
Thank you, Kristen.
Jay, to back us up, maybe the community could ask some questions. Can you tell us a little bit more about the services you're trying to fund? Where are you lacking? Because, in your case study sheet, there were some challenges that you identified, staff turnover, things like that. But in your system, maybe just being more specific about what the gaps are and what the systemic problems are that are posing, these sort of challenges.
Absolutely. Thanks, Kathy. Yeah, I know I kind of breezed through, so thank you for giving me some guidance. So staffing turnover, right? We have, when it's not consistent is one of the areas that we struggle with. Access to certain services that may be a challenge. I'm definitely open to hearing from the community too about some of their challenges or suggestions they may have.
I'll go. So, I and I realize this, obviously your issue is a larger systemic issue with it not being enough funding in general, but when I worked, especially worked for a recovery community center, I think the biggest thing for me was that I really made a point to go out to all of my meetings in like different areas. I go to like my nonprofit networking meeting. I go to, any behavioral health meetings, any type of SUD meetings, but also like larger health system meetings. I'm part of the Williamson County Health Board and things like that, because that all kind of gives you a way to just meet and interact with people. And then when we did get the opioid funding, I actually went directly to the commissioner, who I had worked with quite a few times, right? And was like, hey, I'm interested. Can I write you a grant? Like, can I actually write you a separate grant? Like, because I know you're not asking for these, but and she allowed me to. Didn't end up getting it, but at least that I was able to talk to her, and then approach her with that, because I knew her. And it's a little bit harder to do in places like San Antonio, where it's a little bit larger than, let's say, like Williamson County, just, right outside of Austin. But if you know people, they're still good. I also found out there's all sorts of smaller grants that you can get from like Dell, and from all your local hospitals usually give out a lot of grants. So there's a lot of ways to kind of solicit that if you get to know your community. And just pester people. What I do, I pester people.
Have that quality too. Perfect. Thanks, Lindsay, for your feedback.
I actually really love what Lindsay's saying. I completely agree with all of that. And, I always say poke. Pastor's the same thing, right? Being present and really engaging and networking with all these folks is really important. And then utilizing that network in a very specific way, really making sure that your ask is very much aligned with your values so that they can see that alignment and align with their values, right? Especially when we're working with larger government entities, legislators, et cetera. But also, as Lindsay pointed out, really recognizing that there are lots of on-the-ground entities that are providing smaller grant opportunities. So banks often have grants. So if you have any local kind of federal banks, so banks that are geared toward teachers or military or, et cetera, they will have specific grants that are open. Your clothing stores like Kohl's have grants. They have funded adolescent substance prevention care programs before, and opportunities to just be able to go in schools or to do certain types of activities like, Halloween trunk or treats, just to be able to be out in the community to pass out things. So lots of those other small entities are really great too, can supplement. But I'm also thinking your organization is also looking at lots of different types of expansion and build as well. And I'm wondering, when you're thinking about, really looking at these pieces, are there other areas that might be helpful for us to also give feedback on, or recommendations on thinking about that larger systems change that you might need to really support your larger growth and build? Just throwing it out there too.
Thank you, Leslie.
Also throwing it out there, I run a program for UT called an RSPS Fellowship Training Program. We actually pay an individual, like $5,000 a stipend to get trained, but we also pay the training entity and supervisors. So if you guys have peer supervisors, we're always looking to partner. And we pay for each individual. So, and we're always needing peer supervisors and places for them to do their hours. And that is across Texas.
And just do exactly what Lindsay just did. She just made a pitch, and boy, just keep it going, right? That's a great pitch.
We were talking a little bit earlier before our meeting started, Jason, with our hub team about how there's sometimes a pattern for many organizations where funding and resources are limited to stretch a little bit beyond what you can do comfortably. And then if you get a little more money, to stretch a little bit beyond what you can do comfortably there, so as to be perpetually in this position of quite stretched. It's the nature of the industry. Someone alluded to the macro systems of financing and the struggles, which leads to that, I think, important question around prioritization. Are there particular areas, because we know we are stretched, where we really need to dedicate ourselves? And do we have to make some hard choices around that prioritization? And are we being as efficient as we can be in those prioritized areas? And I would ask that in the form of a question. Are there certain areas where you're thinking, this is the spot where we really want to prioritize our seeking of funding or our expansion effort?
So that was directed to me, right?
Yes, absolutely.
Okay. So I think Leslie did mention we are expanding our residential treatment. I know that we are moving towards having women on our campus. So that 80 bed count for men that we have now will be dramatically increasing, right? So I know that's an area of our nonprofit that is growing leaps and bounds.
So Jay, piggybacking off what Matt said, with that growth in mind and those strategic goals, it sounds like a really focused type of service expansion grant, which I'm sure you have grantors out there looking for that. But if you have staffing issues and you're having difficulty keeping people from turning over, maybe before you really set those targets, go back to your system to see where the sources for that type of turnover and burnout are, or the inability to attract different types of providers, because you're going to need to expand your provider base too, right? You and your staff. So maybe build on a healthy system first and then start attracting people in that way. But I would go back to my system and look at it, your current problems before you started to build more. Because it's like, we were talking about this earlier, it's like having a house and you keep building additions on, but you're not really sure what the original house looked like. And some of the choices you're making are based on the funder's goals and not really your goals. And you're not really keeping your own system sustainable. Anyway, that's my 2 cents.
Well, thank you so much. I really appreciate your expertise and guidance. Thank you.
Thank you. And any other questions or comments, or maybe similar experiences that, we can share here?
I'll just add really quickly, thanks so much, Jay, for sharing your case and your story and the things that you're focusing on. Again, Texas is going to receive a bunch of money from the opioid settlement funds, and recovery supportive housing is high on their list of priorities. I was just checking. I don't see any RFPs out there right now for that. But there is, I can put it in the chat. There's a link to sign up to be notified when RFPs do go out there. And it's tons of money, right? And I think it's a great opportunity for either you and your organization to chase funds individually or to partner with maybe a more established funded organization. So whether that's a university or a treatment provider in your area, to provide like a holistic proposal for the use of these funds. There is an actual RFP out there right now for a naloxone distribution grant that they're doing with the opioid funds. I don't know if that fits into your wheelhouse or not, but that might give you kind of a foot in the door of like how to work through the proposal submission and the actual funds procurement process. So I'll put the link to sign up for more notifications as the RFPs come out in the chat.
That'd be great. Yeah, and I have your email, so I look forward to reaching out for more contact. Thank you.
Of course, looking forward to it.
Thank you, Alanna.
I'm just wondering if anyone else from the community has had similar experiences and want to share anything else that has worked for them, whether it be in that fundraising realm or whether that be in the realm of really looking at growth and having a way to kind of ensure that they're aligning with their values and looking at systematic factors for improvement. Just opening it up to everybody too.
I just wanted to go back to one of the questions that was brought up earlier, and Kathy alluded to it as well. You mentioned that, there's a lot of staffing turnover and, like program cuts, reductions. What have you guys done so far to address that?
So seeing how that's a little bit out of my realm and my scope, where I'm not gonna answer that because I don't know the answer to that. But I'd be happy to contact you afterwards once I have more information on that. I'm so sorry.
So I see a comment here from Kristen to partner with another similar nonprofit and split a full-time grant writer. That's a great suggestion.
I would even go further with that recommendation of partnering with other similar nonprofits and splitting fundraising, and other types of, grant monies in general. Maybe there's other organizations that you can really work with, like Lindsay was talking about her organization and the things that they do. Maybe there's other partnerships that's really going to help strengthen your role, your services that you're offering, and really be able to partner and help to give those benefits to your team members as well, so that it might reduce them leaving as well, help really strengthen your teams there.
Thank you.
Thank you. Any other questions from the community or anything you'd like to share that would help Jay today?
No, thank you so much for your time. I really appreciate it.
Right. Well, thank you so much. I will request Matt to then please provide a summary of the case and the recommendations.
Absolutely. I think we had a strong through line between Alanna and Jay's sharing today related to seeing the big picture, having a broader vision and awareness. Appreciate Alanna telling us to, one, ask the community what they need, and two, do what the evidence shows us is going to work, expanding our understanding of what services are, bigger vision, expanding our understanding of what the community need is, bigger vision of the way, and thinking about who can teach us. Who's there? Who are the experts? There's a wide array of experts in a wide array of areas. I think maybe the most important phrase for today, make friends. Make friends. This came up as well when Jay was talking, as we were sharing the idea of building relationships, making connections, finding ways to have partnerships, also thinking about the foundational systems we need to be able to prepare for growth. How do we make sure that we're consistently aligned with our vision and our mission and our priorities as we think about expanding, so that it's not sort of a tail wagging the dog situation, that we're really trying to focus on what we believe to be most important as we look at funding opportunities for us. Thinking about quantity and quality, as Jay was talking about, the juggling there. But again, back to this critical idea, particularly as it relates to peer support services, where we have a culture of understanding that there are a wide array of experiences and expertise. And so how do we make friends with people across that spectrum to help us to achieve goals like the kinds of goals, Jay, that you're trying to achieve, and the kind of guidance that Alanna was giving us related to enhancing our service systems. Thanks.
Thank you so much, Matt. And thank you all again for joining today's Echo. As a reminder, to earn CME credits, please complete a post-session survey using the link in the chat. If you would like to present a case and share some of the challenges that your organization is facing, please do email us at cstat@utisca.edu. We look forward to seeing you at our next session, which will be on Thursday, May 21st at 12 noon. Thank you and have a wonderful rest of your day. Thanks. Bye-bye.